Thank you very much, Alex. It is very good being a pensioner, is it not? And I strongly recommend it. But perhaps don't hurry too fast to become such. But once you are, enjoy it, because it's a very good time of life, I think. Thank you very much for your introduction, and it's a real pleasure to be here and to see the Art Society and the Israeli Rectal Society come together, I believe for the first time, is marvellous, and let's hope it's the start of continued close relationship. I've got really a sort of easy option in a way. History is great fun. It's interpreted, and I've done my best to be objective, but I expect I will have broken many rules that historians would wish to see put in place in trying to give an objective statement of a particular subject. But at the end of or halfway through towards the end of the 19th century, bacteria were discovered by Pasteur physically, functionally, and by Robert Koch morphologically. And I think rather analogous to what we've seen in the last 30 years in modern science, biological science, with the description of numerous genes and their mutations. So in those last 20, 30 years of the 19th century, numerous bacteria were described over a longer period of time, but for the age, really, when you think about it, at a very great rate. And so diarrhea, which was a very common symptom, or dysentery, in society, began to be divided into those that were evidently infective and leaving a group behind which was not apparently associated with infection. And Hale White, I think, looking through the history, he probably was the first person to say there is this disease which is not infective in nature. And then shortly after, the introduction of limited endoscopy to inspect the rectum obviously increased the scope of physicians and surgeons in identifying and diagnosing and then managing what was then already recognized to be a form of dysentery without infection. And by about 1910, or in this case 1909, this is the Royal Society of Medicine. I put it up because not only is it relevant to our own group coming to you, but it also was a remarkable piece of deliberate putting together of experience in order to get some idea of what people were dealing with when they made the diagnosis of ulcerative colitis. And you can see there a disease with a remarkably high mortality. And of course, a disease that affected young people particularly. And these cases, of course, were immensely tragic within the families in which they occurred. So I'm talking about the surgery for ulcerative colitis rather than the medicine, although just to say that medical treatment for ulcerative colitis was, you might say, not dissimilar to how it is today. A bit of this and a bit of that, and we think it's very good. But surgery started off really as a medium for the application of medical treatment by gaining access to the large bowel through an appendicostomy. The idea was you did an appendicostomy and you poured things like calcium salts and other relieving liquids down it, and you hoped to bring the patient into remission. And Lockhart Mummery at St. Mark's was one of the great proponents of appendicostomy and irrigation, therapeutic irrigation, which he maintained really throughout his whole career. So local medical treatment. But then, shortly after, Brown in St. Louis, USA, described the use of an ileostomy to defunction the large intestine, and not unexpectedly, ileostomy was applied to patients with ulcerative colitis. His case of ulcerative colitis in his original paper in Surgery, Gynecology and Obstetrics, which was the new journal of the newly formed American College of Surgeons, whose centenary it is this year, 2013. That patient died, but the idea of defunctioning took over really from that of irrigation in most people's hands. And defunctioning through the medium of an ileostomy, if you look at these data here, which come from a combination of Mayo Clinic and Leahy Clinic, you can see hugely high mortality rates in these young people. 50%, let's say, mortality in those having an ileostomy. And of course, just like upper GI hemorrhage, surgery was blamed for its high mortality, when in reality the patients were being served to the surgeon already nigh to death, or moribund, many of these people. So the results reflected as much technique as severe illness. And the idea of diversion remained, and I put this up because, again, we are coming to you as a group. The section of codoproctology came out of the section of proctology, of course. And Rupert Corbett, who was a consultant surgeon at St. Bartholomew's Hospital, in his presidential address in 1944, during the war, he gave his lecture on ulcerative colitis, and this was his view of ileostomy, that it can have dramatic results, but surgeons were afraid of doing operations with such a high mortality. And at the same sort of time, perhaps a little bit before, we start on the new theme now of surgical treatment for ulcerative colitis, namely, if diversion has some value but it's highly morbid, why not actually remove the disease part? And there was a debate here with Norbury and Gabriel from St. Mark's on the left, who used irrigation through appendicostomy, with Sir Arthur Hurst, who became the one of the founders of the British Society of Gastroenterology, and Heneage Ogilvie, who advocated the idea of colectomy. And that was a debate which I think they won. But the real data were coming out of the Leahy Clinic, and as you will see shortly, from Canada. And here you see Frank Leahy on the left, and Dick Cattell, born in 1899, died at the age of 61 or 2 from motor neurone disease, one of the great American surgeons of his era, and such a good, nice-looking guy I think he is. He comes over in that picture. And you can see, when they looked at their results at Leahy over that period from 1928 to 52, as they increasingly adopted resection of the disease rather than ileostomy, you can see the mortality fell. And the real obvious evidence for the value of resection or excision came from Montreal, and Gavin Miller was the first author on a paper which I think really set the scene for how effective surgery is for ulcerative colitis. They had measured protein output in the stool in patients with severe colitis. They'd found daily losses of approaching 200 grams, which you multiply that by 10 for 10 days, that's a lot of protein, 2 kilograms of protein, and no wonder they were so ill. So the colectomy was applied, and as you can see, the operation resulted in a smallish series of patients, but without an operative death. And from then on, proctocolectomy was the treatment, and it was curative for ulcerative colitis. And there was a discussion and a development of an approach to trying to manage or to produce an ileostomy that for the patient was manageable. How difficult it must have been to use that appliance on the right. You can see in the middle attempts to cover an exteriorized terminal ileum by skin grafting. Lester Dragstedt, who was more famous for his application of vagotomy to peptic ulcer at the time, receiving a diploma from the Royal College of Surgeons of England. But these didn't really find a satisfactory solution for the patient till Brian Brooke, who was professor of surgery in the University of Birmingham before he came down to St. George's Hospital, London, introduced in a very important paper, 1952 in the Lancet, the everted ileostomy. So the scene was set at that stage, for a curative procedure, with, but at the expense, of course, of the patient having to have an ileostomy. And I put this up just as a matter of historical interest. We've heard the tripartite meeting referred to, but before it became a tripartite, it was a bipartite between, it was the Anglo-American proctology meeting. And they used to go across, they used to go across either by aeroplane or by boat and take a few weeks and have a nice relaxed time. And on this occasion, this was first occasion held in London, they all agreed this was the operation of choice for ulcerative colitis. You see Henry Thompson there on the right as the president of the British side, and you see Dr. Carl Zimmerman, president of the American Society of Colon and Rectal Surgeons, which had just become that from the American Society of Proctology. And I put this up really just for those who might have known some of these people from St. Mark's. Only two of them are alive. Basil Mawson, their third from the right in the back row, standing next to Ian Todd, who is still alive, but all the others have passed on. And in the middle there, the bottom is Gabriel, with Naunton Morgan on his right and Milligan on his right, and then Cuthbert Dukes over on the far right or left as we look, and Lloyd Davis, Gallagher. It's good. You know, it's just nice to see, and Lockhart Mummery's there. There they all are, and Alan Parks, of course, up there on the top right side. And Gallagher, in his publication of his treatment for ulcerative colitis, 1966, as you can see, was performing proctectomy with ileostomy on the vast majority of patients. So we come to the last 5 minutes or so of the history in which, of course, concerns ileostomy avoidance. And that goes back a long way. Devine from Melbourne, Australia, who's obviously a very inventive surgeon, had applied a four-stage procedure to achieve what amounts to colectomy with ileorectal anastomosis. Then Aylett in London used this operation exclusively, pretty well exclusively, for all patients with ulcerative colitis, with, as you can see there, reasonable results, and nobody's been quite able to understand how many of them seem to be satisfactory, even though they had very severe proctitis in the residual rectal stomach. But it was apparent that this was not going to be entirely a solution that everybody would accept, every surgeon or indeed patient, for these reasons. And so, going back again to the early 30s, Nissen, a very gifted German surgeon, actually German Jewish surgeon, published a case report in the Proceedings of the German Surgical Society, published in Zentralblatt für Chirurgie. And this was of a young boy, a 10-year-old boy with polyposis, in whom he took everything out. He joined the ileum to the anus, and he says that the bottom stool was and full continence was achieved. So this was a case report, but Mark Ravitch, whom we heard of just in the last lecture, Mark Ravitch and his colleague Sabiston applied this to 2 patients with polyposis, and then subsequently to ulcerative colitis, colectomy with ileoanal anastomosis, which became subsequently known as the straight ileoanal anastomosis. And these 2 cases did well, and although the operation remained in abeyance for many years because of its frequency and urgency of defecation, particularly in patients with ulcerative colitis, nevertheless, further progress in using the ileoanal anastomosis was undertaken. And here is Harry Bacon, another great surgeon of the 40s and 50s, Allentown, Pennsylvania. Kubchandani is his remaining resident. You all know Dr. Kubchandani, no doubt. And he used the model of canine model in order to try and see whether adding reservoir function to the straight ileoanal anastomosis would be a useful functional addition. He didn't really succeed because many of the dogs died, and it wasn't really possible to conclude that adding a reservoir to the reconstruction was going to help patients. Another attempt at reservoir or rectal mucosal replacement came from Donald Peck, who was very active in the field. He took a segment of small bowel, which he stripped the muscle off. He used the mucosa, which he then put into the rectum, having taken the rectal mucosa out. This hasn't really worked out, one of the problems being that small bowel mucosa is itself liable to inflammation, which now we'd call pharyngitis. But Niels Koch was really the first surgeon to demonstrate a successful application of a reservoir type of reconstruction in surgery for ulcerative colitis, and indeed he developed the Koch reservoir primarily as a replacement for the bladder after cystectomy. But it was applied and converted into a sort of continent ileostomy, as you will be aware, and he applied this to humans, demonstrating that you could live a healthy life having a reservoir. And of course there was a whole era where Scandinavian surgeons mainly were doing this operation until Alan Parks came and combined several of these previous historical developments, namely the complete removal of the colon and rectum, namely the idea of a mucosectomy, which I haven't had time to mention, but Devine was the first to show that you could elevate the mucosa by saline injection and strip it off, scissor dissection, and then the application of a reservoir and the use of the ileoanal endoanal anastomosis, which he himself had contributed to developing. So at that stage, I think I stopped with the history, because the history subsequently is something that I think probably amounts to actual practice today. So thank you very much indeed.